now that started the TCTAP 2012-22 case session started. This session, including the 6 presenters, so the first and then 3 panelists joined us. Please discuss aggressively. So I introduce first speaker. Presenter is the Dr. Namidin Makham from the Uzbekistan, titled Intravascular Ultrasound Guided Controlled Retrograde Tracking After Failed Anterior Antegrade Dissection Reentry. Doctor, please.
Today, my presentation is dedicated on intravascular ultrasound guided controlled retrograde tracking after failed antegrade dissection reentry. This case was done in Bad Krozingen with Dr. Kambis Mashayekhi. I was an assistant. Now I'm working in Federal Clinic in Uzbekistan. I don't have any potential conflicts of interest. The patient is 70 years old with clinical symptoms of stable angina. He has also some hypertension, dyslipidemia, and family history. On 1st of October 2021, patient underwent coronary angio, where was realized 2 vessel disease of CTO of right coronary artery and significant LAD stenosis. So they were recommended for CABG, but patient denied it, the CABG. So 3rd of November 2021, patient was referred to the University Heart Center Bad of Krozingen for PCI. By ECG examination, there was a left-sided type with small q. In the echo, there was a normal size and normal function of left ventricle, and the aortic valve is fibrotic, mild stenosis with the mean pressure gradient 13. So this is the coronary angio. As you can see, there is a total occlusion of the right coronary artery from the proximal side, and the distal, as we can see from the left coronary artery, there is a retrograde up to the proximal side of the right coronary artery. So we suppose the vessel anatomy of the right coronary artery as the typical, and there was just a short occlusion. So we done a biradial approach with the 7th French to the right coronary artery AL1 and the Exabax 3.5 to the left coronary artery. We attempt to integrate with the wire escalation from XTR to the Gaia sort. Unfortunately, we couldn't pass the CTO lesion. So by JCTO score, this was a 2nd. As you can see, there is ambiguous cap with some tortuous lesion. So multiple failures of puncture, the distal cap wire escalation strategy from even with the support of dual lumen microcatheter Sasuke, we tried with SUO, Fielder XTR, Gaia Cert, and even with Confianza. And then we did the super selective analysis of epicardial ipsilateral. Finally, decision was to change the strategy based on the high risk of collateral damage. So what was the next option? IWUS guided puncture of the distal cap. So we put the IWUS, but unfortunately we also failed with IWUS guided antegrade puncture with the wire Confianza due to the missing of visualization of the distal vessel based on the calcified plaque. So as you can see in the IWUS of the proximal cap, there is this is the middle part of the right coronary artery, and we can see the calcified distal cap. So we couldn't pass the distal cap of even with the Confianza. So we did a next option. Was the initial knuckle wire through the distal cap with the distal wire reentry with the support of Stingray balloon. So we did an antegrade dissection reentry with Gladius. It was nicely proved, and then guideliner assisted antegrade reentry attempt with the Stingray LP. As you can see here, in the distal part we had the Stingray, and we tried several times to attempt to cross the true lumen with the Warrior 14 gram with failure to re-enter. So our last option was the IWUS controlled antegrade re-entry versus retrograde septal surfing. So what we did, we switched to retrograde septal surfing with Sion and Caravelle with IWUS controlled retrograde wire tracking. We passed, as you can see, with the septum to retrograde. And this is the IWUS with visualization of the retrograde wire, the true lumen, and IWUS in the false lumen. As we can see, here is the IWUS in the false lumen, and this is the true lumen. the wire, retrograde wire from the end till to the app is in the true lumen. So this is the angio of the after first stent implantation. So the retrograde was placed the whole way up toward to the distal cap of the CTO in the true lumen controlled by iris. Therefore, only limited stenting was necessary. We just implanted one stent, 3.5 to 28, and then we just want to see the middle part of the right coronary artery. How is it looking by iris? So we check the iris and to analyze the middle part of right coronary artery after the first stent implantation. As we can see, there is a circular compression of the true lumen in the middle part of the right coronary artery with some hematoma, and there is some dissection, as we can see in the second screen. And there is a video also that we can see the iris. There was some dissection and calcified lesion in the middle part of the right coronary, but stent was the first stent was in the well position and fully expanded. So this is the final angio after second stent implantation, and in the second screen you can see there is no any complication with the retrograde channels. So this is the final iris after second DES implantation, the fully expanded stent, and we already blocked the dissection area, and there is no any compression in the middle part with the hematoma. So our conclusion and take-home message was that never underestimate simple CTO lesions, and CT prior to CTO PCI could have given important information about the plaque composition of the distal cap. The third is the failure of distal cap puncture often leads to hematoma and loss of visualization. ADR is an option to overcome the distal cap calcification, and in case of large antegrade dissection, retrograde bailout rescue is possible. The next one is the iris controlled retrograde tracking is very useful to minimize stent lengths and optimize the stent placement. The large antegrade dissection rescued by retrograde true wire position will heal after covering the true to true crossing by minimal stent lengths. And the last our take home message is be always flexible to change the strategy for optimizing patients' long-term outcome. Thank you very much.
Thank you very much. Very complex cases, but finally that very successful. Please give me a comment from the panelists.
Yeah, I think it's a challenging case. Yeah. It's a proximal RCA total occluded, and also the lesion length is quite longer. So from the bilateral injection, I think the first choice of our operator is use the ADR. I think I fully agree with. Finally, after fail to puncture the distal cap with the retrograde guidance and also with the antegrade iris guidance, re-entry is into the true lumen. It's a very smart. I think it's a very smart strategy. So final result is quite good. Congratulations.
Thank you very much. If you have questions, I will be happy to answer it.
From myself also, congratulations, good case. And I like it is always during intervention, is always good to change the strategy. Always single strategy might not work, and you have to be consistent with the changing of strategy that I did. Thank you.
Thank you very much for your comment. As your comment was good, we already wrote in our conclusion, and the last take-home message was the same. Be always flexible.
Okay. Yeah. My personal comment that I think the intravascular ultrasound very helpful bail out your such kind of situation. But if I do the more early switching to the retrograde approach, but finally very nice results. Thank you very much. Nice presentation. So move on to the next session. Next speaker is Dr. Igor Buzanov from Russian. Titled Real-Time Hybrid Visualization Modality Combined Fluoroscopy and Segment CT Scan Facilitate Transcatheter Left Atrial Appendage Closure Procedure. Doctor, please.
Thank you very much. Thank you. For me, it's a great honor to be on this conference because it is really great, one of the best world conferences in the world, and I'm very honored to be here. Thank you very much for invitation. So I will speak about real-time hybrid visualization modality, combining fluoroscopy and segmented CT scan. So I have disclosure honorarium from Philips in past, and this is the typical atrial fibrillation patient. The atrial fibrillation was detected by ECG during outpatient clinical exam. The complaints of irregular heartbeats and shortness of the breath since 2018. Before the catheterization, we did the transesophageal echo and Doppler, and we see the spontaneous contrasting of the left atrial cavity with a blood flow and without signs of any blood clots. The size of LAA was 1.9 and 3.8. So we did the CT scan and measured the size of the left arterial appendage and the volume of this. It was very crucial, important to the combining the fluoroscopy with CT scan. So then CT scan is uploaded to the angiographic system, to the cath lab, and we can see the CT segmented scan over the fluoro. And we used usual right femoral venous approach, made arterography, and check the aorta is the same as we see on the CT scan. And then we need to make the transeptal puncture, and because the LAA closure is preventive procedure, we don't have rights to be wrong and make the error mistakes. Any imperfection makes the program meaningless because of the complication rate. So that's why any tool to help us to prevent complications is very, very useful. And during the transeptal puncture, paramount importance to understand X-ray negative structure like the atrial septum, like the LAA ostium or LPV position in all CR positions. So after transeptal puncture, pigtail catheter was placed in LAA, and we did the contrast injection, and you see that the correspondence of the angiographic picture with the CT scan, and also we see the entrance of LAA, and there is a point here that it was made on CT scan. It is the position, planned position of the device. So then here is this point. Then we put the pigtail and change to delivery system and use this marker without contrast injection to position the device. So this is transesophageal check and contrast injection. We did pull and push maneuver and see the precise position of the device because we have a landmark. Usually we do not have the direct landmarks when we are opening LAA, but it is best practice to make it from the first try. So this is very precise position, and patient was discharged home on next day. At 2 months, there is no problems with the residual leaks or the strokes. So take-home messages: the hybrid visualization modality by Heart Navigator allows us to merge segmented CT scan and real-time fluoroscopy. Heart Navigator system turned out to be useful to visualize X-ray negative structures and landmarks without contrast injection. During LAA closure procedure, there are at least 2 crucial procedure steps when the good understanding of anatomical landmarks is very important. This is transeptal puncture and the implantation of LAA occluder. And it must be done in correct position. So Heart Navigator during LAA closure procedure may be the key to success to define the relationships and landmarks of these anatomical structures. And also I have a 20-year experience in interventional cardiology, but anyway, I learned from this equipment because the rotation of C-arch help to understand the position of anatomical objects. So this is very good, very useful technique that it is non-invasive but helpful in closure LAA. Thank you very much.
Very nice presentation. Very new hybrid technology. Very interesting. Please discuss. Please give me a comment that, from the panelists.
So I have one question for the presenter. So for AIA occlusion, I think routinely use TE guidance, but you do the Floro and with heart navigate system, hybrid guidance. So in your daily practice, so how many % procedure for AIA you will use this kind of hybrid modality guidance? And in what scenario where you will still use the TE guidance? Thank you.
It is a great question. First of all, we don't exclude TE during this procedure, so it helps to move with our devices, with our instruments, because interventional cardiology look to the fluoroscopy screen first. We cannot open the device on TE only. So that's why we also always use the TE as it is possible, but this is just additional tool to help us to understand in real-time mode all correspondence of the X-ray positive and X-ray negative structures. So TE sometimes have the contraindications, for example, the esophagus problems and etc. But we usually do that parallel.
So,
other comment? Yeah,
just for a comment. So I think this technology has helped as a complementary to supplement the good decision, and that will be very crucial for the patient, because we cannot have the complications so far feasible. We have to minimize, and I think that modality might be helpful in future. I think when the cases will increase, and then we'll know the exact advantage, whether it's really advantageous or it is just part of use of the newer technology only. Thank you. Nice presentation.
Just some questions. Thank you very much for your nice presentation. It was great to see that. And then I would like to ask how many contrast injections have you used? How many contrast you use in this case? And then if you are already controlling with the hybrid positions, even with the heart navigator and TE, I think that we don't need any contrast injection. And second one, can we use without any TE if we are using this heart navigator? So we don't. I think that we don't need the TE. It's just my opinion. I would like to ask you, hear your opinion. Thank you.
Thank you very much. It is a good question, and because the TE is the gold standard to this, we cannot waste it from the protocol. And usually TE result is the same as the CT scan. We need the contrast injection first step to synchronize the CT scan with the fluoro image, because this object, 3D object, should be placed in the correct place of X-ray screen. And then the second contrast injection will be in the LAA as usual, when we are checking everything, understand the size, recheck the size, and something like that. So you can do it without the contrast, but I think it is a good step to make a contrast when we put the pigtail and put the delivery system there.
Thank you very much.
Thank you.
Okay. Doctor, thank you. Nice presentation. Very good discussion. Thank you.
Thank you very much. Thank you.
Next speaker is presented by the Dr. Pa Hai Ho from China. Title is the How MCS Save Lives. Doctor, please.
Thank you, panelist and moderator. I'm Carmen from Hong Kong, so I'm talking about how MCS save lives in my case. So this is a 58-year-old gentleman who came into the A&E department for confusion and so chest pain, but upon arrival, he already have hypotension. And this is his ECG. So we can see that there is ST elevation over the inferior lead, and the posterior ECG show that there is also ST elevation over the posterior lead here. So this is his vital chart, and he's in a profound hypotension with inferior posterior STEMI. He was put on dopamine and also adrenaline and also fluid resuscitation. And because of very borderline saturation, we decided for intubation before we proceed to primary PCI. But unfortunately, after intubation, the patient had PEA arrest, and we started CPR. But luckily, the patient circulation regained, but still rely on very high dose inotropes. So this is a case of inferior posterior STEMI, and we are facing a patient with severe cardiogenic shock requiring double inotropes. And the patient also have APO and was intubated and has a brief PEA arrest after intubation. So he now is coming for primary PCI. So how you plan for PCI? Planning is very important before we proceed. If mechanical circulatory support is needed, I think all of you will agree with me that yes, because the patient is in profound shock and not just have a PEA arrest, we will need an MCS for this patient. So next question is what type of MCS? We have IBP, we have impeller, we have ECMO, or the combination of the above. And also the third question that will always in the debate is whether you perform the PCI first or MCS first. So whether you perform PCI and MCS and whether MCS is needed, this is a chart that I adapt from the SCAI. So it actually depends on the current anatomy, the patient comorbidities, and the hemodynamics. And indeed, before you know that the current anatomy of our patients, or the patient is actually have a very high risk of deterioration and very high risk of PCI. We have a very poor LVEF, shock, ACS presentation, decompensated state, and they will suggest you to consider support first. So what we plan for ECMO first, then we proceed to PCI, and then we plan the impeller for LV venting, and that's our plan. And while we puncture the right femoral and also right femoral vein, the patient developed an other arrest episode, and we started ECPR, and we put in the ECMO, and then we proceed to our PCI. So this is what the coronary angiogram show. We can see that there is a mid-circumflex total occlusion, and the LAD is very bad with multiple critical stenosis over the whole proximal to mid and also distal LAD. The RC is small. So the culprit vessel is the circumflex, and we successfully wire with a workhorse wire. And this is the angiogram that we obtained after wiring. We can see there is a attetic vessel over the middle distal third, tight stenosis over OM2, and we pre-dilated, and we did an IFIS. This is from the OM2, and we can see there's very severe stenosis here. And now we are in the normal segment in the mid-circumflex. And then we see another very severe stenosis here, and all the way up to the proximal circumflex. Therefore, we decided to do stenting, and because of the significant size mismatch, we need to put in a biofreedom stent from the OM to the distal third, and we put it with a 4.5 non-compliant balloon, and then we put in another stent, not overlapping from the proximal to mid circumflex. And like in all STEMI cases, we develop no reflow. And in our center, we usually give adenoscan. And after giving multiple bolus of adenoscan, the flow, TME flow, free flow obtained. So now we have the circumflex fixed. The LAD is not a culprit, but have multiple critical stenosis. We decided to treat the LAD as well. We wire it with a workhorse wire the diagonal for protection. We do some balloon dilatation, but I didn't show here. And then we put in stent over distal LAD. and also from the osteo to mid LAD, as shown here. But the distal stent edge have some dissection, and we put in other stent here. So this is the final angiogram of the LAD. The diagonal is still here with a wire protection, and we have TMA free flow from the LAD. So the progress is after the reperfusion, after revascularization, we put in the impeller for LV venting because the patient is on ECMO, and then we also put in a reperfusion catheter, and the patient actually have a LV improved, and we give the patient of 1 dose of levosimendan, and patient successfully wean off the ECMO and also the impeller afterwards. So there's a case about AMR with cardiogenic shock. Always a debate about whether you go for MCS or PCI first, but I think in this case, who have a severe profound cardiogenic shock, MCS does save life in this case. And whether we proceed to PCI to non-culprit vessel in cardiogenic shock, I think a lot of debate, a lot of trial going on, but I think it all depends on the coronary anatomy. I think if you all see this predicate stenosis in LAD, I think you will all agree with me that you would do PCI to LAD too. And adenosine is very good to treat no reflow. I know some centers use nitrite or adrenaline, but nitrite have hypotensive effect, which is very contraindicated in this case. Adrenaline causes arrhythmia, but adenosine is very short-lasting, doesn't cause hypotension, very good drug to use. So my conclusion is MCS play clear role in AMR with cardiogenic shock. And while you're planning for your revascularization, you can use those objective assessment to guide your plan for whether MCS first or PCI or whether MCS is actually needed. So that's the end of my presentation. Thank you.
Thank you very much for very complex cases, Dr. Ho, but very good strategy that saved a life. Firstly, I ask to you, this patient, that finally LV function, LV ejection fraction, how much that after before the discharge?
Before the PCI is only 15, but afterwards, after the PCI, it improved to 30 something. Yes, and able to win off all those inotrope and also mechanical support.
I see. Thank you. Okay, please open the discussion. Please comment from the panelists.
So for this particular case, I think it's a severe cardiac shock due to the non-STEMI patient. For the particular case, because the hemodynamic is so unstable during the admission. So I think first we should insert ECMO like for this case MCS, then do the angio for this case. For this particular case, I think it's a triple vessel disease with the left circumflex dominant. So for this kind of scenario, I think we should we should complete revascularization for this particular case. So I have one question. I didn't notice that. So after the procedure, the prime PCI, you insert the impeller to give more support for this patient. Is that right?
Actually, because ECMO increase does give the patient a lot of afterload, which is very bad for the heart because the patient is actually have a failing heart. So in our center, we will put in an impeller for LV venting, hopefully to reduce the clot formation in the LV. And also it will help in winning the ECMO because with the impeller in hand, you can reduce the ECMO flow and increase the impeller flow while your heart is improving. That's a very good strategy to have your impeller inside. But if your impeller is not there, we also put in IBP for reducing the afterload for LV venting.
Okay, good. So how did you withdraw the impeller and also the ECMO? So how long maintain the impeller and the ECMO after procedure?
For this patient, we only maintain the ECMO for 3 days, but and we win off the impeller 5 days afterwards.
Okay.
So
perfect.
we usually win off the ECMO first. Yes.
Okay, thank you.
So very nice case. Yes, MCS is very important while doing the complex angioplasties. I think nicely presented. Is there any complications like other complications associated? Did you have that made you difficult to win? Like other organ, sometimes the patient in shock will develop multi-organ dysfunction. So did you get in this case or not?
this case is very fortunate that the patient actually have no organ dysfunction with this, because we actually saved the patient quite early. We put in ECMO quite early before, yes. So very luckily, the patient have not much organ dysfunction, but actually we do see other patients who are very unfortunate and have organ dysfunction like bleeding, renal failure, stroke from ECMO, and also from the shock. Yes, this case is very fortunate.
Okay, that's nice.
Okay, thank you very much, Dr. Ho. Very nice presentation. Okay, thank you. Yep. Next, the fourth presenter is Dr. Chang Ho San from Malaysia. Title is "The End is Only the Beginning of Our Nightmare: Managing Rare Complications of Percutaneous Closure Devices." Doctor, please.
Hi, greetings everyone. I'll be talking about a topic about basically the end is only the beginning of our nightmares, managing the rare complication of percutaneous closure device. So I have no disclosures. We have a 75-year-old lady who is hypertensive but otherwise very ADL independent. She presented with a late presentation of myocardial infarction. Coronary angiogram reveals a three-vessel disease, which we successfully performed a challenging angioplasty to the right coronary artery via the right femoral route. Prior to closure, we did an angiogram to assess the status of the femoral artery. As you can see, it is not diseased. The puncture was not at the bifurcation site, and also it's not really a too small a vessel. So there's no contraindications to do a percutaneous closure. So we decided for a percutaneous closure with a ProGlide device. The procedure of closure was quite smooth sailing. There was no resistance whatsoever, and there was no significant bleeding. However, post-closure, we assessed the pulse and we revealed there was an absent femoral pulse on the right side. The affected peripheries were a bit cooler and the pulse was absent distally. However, fortunately, the patient remained pain-free and asymptomatic. We did an urgent bedside ultrasound Doppler, which revealed an absent flow across the common femoral artery. Initial suspicion was, of course, acute thrombus formation at the femoral artery. So as we can see, a repeat angiogram shows that there is an acute occlusion of the right femoral artery. Digital subtraction angiography showed the same findings along with a lot of collaterals, hence probably causing the asymptomatic nature of this patient. So we decided to perform a PTA. So what we did was we changed the initial 6-French sheath on the left side to a slender 7 sheath. Using a crossover sheath, we guided the JR35 5-French guiding catheter to the right femoral artery. We used multiple attempts to cross the lesion. Many wires were used, including the workhorse wires like arthroscopy, Fielder XT, and command wire. Finally, after much difficulty, about an hour plus of attempting, we finally managed to cross the lesion and with establishing minimal flow across what we see as a puckered lesion. So as you can see, the difficult on this side here, there is a difficult wiring. You can see the buckling of the wire despite multiple attempts. So it's very difficult. It's a very hard lesion. If you feel it, it's a very hard lesion. Okay, so fortunately, we were able to finally wire down this lesion. And in the repeat angiography, we can see that there is a subtotal stenosis of the femoral artery, with which appears to be circumferential in nature. So the initial suspicion of thrombus was refuted when there was no thrombus aspirated at all via the export suction catheter. We attempted multiple times, and not only there was no thrombus, there was also no change in the lesion characteristics. Hence, we decided to predilate the lesion with a Rouvet 3020 semi-compliant at high pressure, 20 atmospheres. It managed to somewhat open up the lesion, and now that we open it up, we also noted there was a leak at the lesion site, which we suspect may be from the previous puncture. So this is our Rouvet 20 Rouvet 30, sorry, at high pressure. So despite having inflating fully, you can see there's a bit of narrowing or shouldering here, which is the site of the lesion. Post dilatation, you can after the dilatation, sorry. So you can see that there is much improvement down the femoral artery. However, at this side here, there is now leaking or oozing from the puncture site. So we are afraid of bleeding and internal bleeding and everything. So we initially decided for a covered stent, but we deferred as we do not have an appropriate length covered stent at that moment. We only had one that was fairly long, up to close to the aorta area. So that's definitely not appropriate. And this is we still plan to do a left main LAD stenting for this for this lady as well. So and her vascular access both radius wasn't that great. So we decided for an alternative approach, which was a prolonged balloon inflation with a PTA on the wire mass tank, 5 mm by 40 mm by 135 at 6 to 8 atmospheres for 8 minutes for a total of 40 minutes. So what it means here is that we inflate it for 8 minutes, let it deflate it, let it breathe for a while, inflate it for another 8 minutes, so we have a total accumulated time of 40 minutes of inflation. And fortunately, the leak gradually sealed off and the lesion, the stenosis actually appears to be almost normalized. So what we see at the final ESA, you can see that there's very good flow down the vessel, only minimal irregularities at the wall, and no more leakage from the puncture site. So it was quite successful. Nevertheless, we sent the patient to the CCU for monitoring. Her hemoglobin remains static and stable throughout admission, and we successfully did a PCI to the left main and LAD the following week to the left femoral artery. So in conclusion, although percutaneous closure device is an effective method in femoral care, we must be always prepared for its potentially rare but dangerous complications that may arise and manage them with a delay. Good practice to assess the femoral pulse and distal pulse after usage of such devices. Fortunately, vascular surgery can still be prevented with prompt interventions from our peripheral vascular intervention team. That's about it.
Thank you. Very interesting cases, and then they unfortunately bailed out very successfully. So that they please discuss. Please give me a comment from the panelists. Yeah, please, John.
Yeah. For this case, we have also met some kind of case, especially when do the structural heart disease like a TAVI procedure with ball size shears with sometimes we use 2 ProGlide. There will be, I think, 8 to 6 rate of failure when we use ProGlide. So for this scenario, I think the operator successfully treated with percutaneous with balloon angioplasty with lung inflation. Considering there will be another PCI procedure. Another option is we should get the support from our vascular surgeon because for this complication for surgeon, actually very easy to treat it. Thank you. That's my comment. Yeah.
Dr. Gautam, please.
Yeah, I think it's a very good learning that we have to be keen post-procedure. Always we are generally discussing about procedure, but post-procedure care is also important. What it says from this complication, and we have to be keen on noticing at earliest moment. And I think this case is detected early and done managed well. Thank you. Nice presentation.
Okay, thank you very much, Doctor. Okay, move on. Next panelist, next speaker. The next speaker is Dr. Shah from the Nepal. Title is the self-opposing dedicated coronary stent in an ectatic lacune. Doctor, please.
My case is a placement of a self-opposing dedicated coronary stent, exposition S by Stentis in an ectatic RCA. It's the first such sort of stent that I have implanted in my cath lab. Let's proceed with the case. There are no any disclosures to be made. My patient is a 70-year-old gentleman, type 2 diabetic, and he had a urinary bladder neck contracture. And he was referred to us from urology department as a part of pre-op cardiac assessment. On evaluation, he had effort angina, and despite being on optimal medical therapy, and he had T-wave inversion in inferolateral leads. So we proceeded with a coronary angiogram as a part of CAD evaluation preoperatively. This was my finding on angiogram. we proceeded with right radial route, and we found that there is 90% stenosis in proximal RCA, which is dominant and is ectatic in nature, with vessel size almost 5 to 5.5. And left system showed moderate disease in the mid LAD involving second diagonal. So here we decided, being RCA ectatic, we decided to go with a novel stentis. I chose middle-sized stent, which range from 3.0 to 3.5 and can go maximum up to 5 millimeter. Using the right radial route, using JR 3.5, we proceeded with the case. As you see, since this is a new technique with some which is quite different than balloon expanding stents, so we have to keep few things in our mind that I have listed out as a 5 golden rule to proceed with this case. So first thing is that the stent size selection, it has to be very clear that whether you are going to use small, medium or large size stent, depending upon the vessel size. Second is the adequate lesion preparation, because these sort of stent, the stent balloon are not designed to expand the stent. Basically, they are to split the splittable outer sheath, which I'll be showing you in the picture afterwards. Third thing, so what we have done is that, let's go one by one. We have pre-dilated the lesion with 2.0 and 3.0 15 NC quantum non-compliant balloon using 18 to 20 atmosphere, and then we chose medium size stent is self-opposing stent. Self-opposing stent means, I'd like to give you a short overview of this stent. This stent has 3 components. The innermost is the balloon, semi-compliant balloon, which is used to split the splittable outer sheath, which you can see clearly in this picture, the outermost, and middle is the stent. So similarly, this is the picture where you can clearly see how the sheath is encasing the whole system. So since the outer sheath is very slippery, the most important thing is precise positioning of the stent. Because of the slippery outer sheath, the stent keeps on moving back and forth, keeps on rocking back and forth. So in order to precisely position it, we need to engage the guide deep into the ostium, well into the ostium. Second, we ask the patient to breath hold so that there is minimal movement during stent implantation, which is the basic rule. And as you see here, we have deployed it to atmosphere of 12 to 14 atmosphere, and you can see there are 4 dots. Whether it's clear to you or not, the larger dots, radio opaque dots, signifies proximal and distal edge of the balloon, and the smaller dots signifies the proximal and distal edge of the stent, so that you can see where your stent has been actually positioned. So next thing that we need to keep in mind is that after stent deployment, the retrieval of the system, because when you tend to inflate the semi-compliant balloon, the outer sheath splits up and it gets jailed in between the vessel wall and the outer portion of the stent. So if you tend to pull it too hard, then what happens that your guide may suck in and you may cause dissection. So in order to avoid that, what we have done is that we place the wire very distally, and we have disengaged the guiding catheter well into the aorta outside the ostium, and with a reverse daughtering technique, the intermittent pulling effort, we were successful in retrieving the whole system along with the sheath, jailed sheath. The fourth point, the ultimate point after retrieval of the sheath is that we need to take care see whether there is any under expansion or not. Like in our case, you can see there is significant under expansion still after 5 minutes of the deployment. So we chose NC quantum 4.515 and we went up to 18 to 22 atmosphere. And this was the final result, which shows TIMI-3 flow with minimal residual stenosis. And next is the following 6-month angiogram, which doesn't show any significant ISR or significant underexpansion. The patient is doing well clinically. So I think there are, in order to master this new technique, we need to keep in few things in our mind, five that I have jotted as a 5 golden rules. Like the first is the appropriate stent size selection. Second is the adequate lesion preparation. Third is the stable and precise positioning technique of the stent. Fourth is the cautious disengagement of the guide. And fifth is if there is any significant under-expansion to be followed by post-dilatation with a non-compliant. So it's not a very cumbersome procedure, though it was my first-hand experience, but we didn't came across any sort of complication. So my conclusion is proper indication, learning curve, and technique to master this new system is of paramount importance, but we need to follow the basic rules, which is actually derived from our basic PTCA rules itself. Regarding its efficacy in terms of repeat revascularization, stent failure possibility, and other hard endpoints like MACE is to be studied in large controlled trials, though we have apposition 4 trial which speaks that it is non-inferior to stent expandable stent, but still I guess more large randomized controlled trial is required to validate its worth in real world practice, and so has been demonstrated in our 6-month follow-up angiogram, which is quite acceptable. The result is quite good. So I'd like to conclude with this final remark. Thank you. If any queries, I'd like to answer those.
Thank you very much for the past experience of this case. The time is limited. Please give a short comment from the panelists. Dr. Chang, please.
So congratulations for this novel stent. So is this expandable? It's a self-expandable coronary stent for this novel stent. Yeah. So maximum overdilation meter.
Means the medium size can be maximum expanded up to 5. Similarly, the larger stent has more caliber to be expanded, large size, and the smaller they have the maximum limit. Like 3.0 to 3.5 can be expanded up to 5. And since nitinol is the platform, when it acquires the body temperature, it starts self-expanding and takes the contour of the vessel.
Okay, good. So in my option, I think if you can do the iris check after procedure, there will be better to detect is there any minor malapposition of this
of course.
Stent. Yeah, because from the angio, I think it's a huge vessel. Maybe the vessel size is larger than 5 millimeter.
Yes, of course. That is the reason we opted for this self-expanding stent.
Dr. Gautam, any comment?
Yeah, it's a nice case, and I think it was very useful in ectatic vessels like with large vessels. So if you have the availability of both, like balloon expandable stent as well as self-opposing, so which one you prefer? Is it very difficult to proceed with in this self-opposable, or it's not a deviation from the usual standard balloon expandable stenting procedure?
Actually, learning technique wise, it is very different from the balloon expandable technique, because there we don't need to care much about the precise positioning. I mean, it doesn't rock and forth too fast, and then the main point where we need to be careful is when we take out the gelled outer sheath, which is strapped inside the outside the vessel. outside the stent wall and inside the vessel, which has to be taken out quite carefully. If we know the technique to do it, then I think it is as good as, and it has been shown in number of trials, non-inferior. And actually, apposition 4 trial, at 4 months, the apposition has been better than balloon expandable stents. But at 9 months, in STEMI cases, the apposition seems to be moreover similar in both the cases.
Okay, thank you.
Thank you. Thank you very much.
Thank you.
Okay, next, move on. The final presenter this session, Dr. Sena from the Turkey. Title is the Incidental Dedicated Overlooked Coarctation of Aorta During Cerebral Angiography. Doctor, please.
Hello to everyone. I am from Turkey, and now I will present a case about incidentally detected overlooked coarctation of aorta during cerebral angiography. We have no potential conflict of interest to disclose. Our patient was a 57-year-old gentleman, and he had hypertension and coronary artery disease history. He was ex-smoker, and he admitted to emergency room with weakness in right arm last year. His past medical history revealed that he had undergone a coronary angiography via transradial approach in 2017, and multivessel disease with high syntax score was detected, and so patient underwent CABG. 3 years later, he presented with bilateral lower extremity claudication, and peripheral angiography was performed, but there was not any stenotic lesions in lower extremity arteries. His medications were including dual antiplatelet regimen with pantoprazole, metoprolol, perindopril, indapamide, atorvastatin, and spironolactone. His physical examination revealed pathological heart sound as S3 was positive, lung sounds were clear, femoral artery pulses were weaker than radial pulses, and neurological examination was normal. Laboratory parameters were normal, complete bleed count, kidney and liver function tests, and cardiac biomarkers were all normal. And so head and neck CT angiography was performed, and sacral aneurysm at left anterior communicating artery was detected, but bleeding was absent. Brain MRI was also performed, and no ischemic lesions were detected. Cerebral angiography was planned with the aim of endovascular treatment of sacral aneurysm, but coarctation of aorta was detected during the beginning of angiographic procedure, and catheter couldn't be passed through the coarctation. Now here in ECG, we can see normal sinus rhythm with left anterior hemiblock, but both of the Sokolov-Lyon and coronary criteria were failed to detect left ventricular hypertrophy, and echocardiography yielded a slight left ventricular hypertrophy with normal systolic functions and valvular functions. X-ray shows costal notchings, and cardiac CT was performed in order to both evaluate CABG grafts and detect any possible additional congenital defects. And CABG grafts were patent, and no additional congenital defects were detected. Postductal coarctation was, as we see in this image, was detected. Arthrography was performed. A PCI catheter was placed via transradial artery, and a translesional gradient was 30 millimeter mercury, and a stiff wire was passed through the lesion via femoral artery. Herein we see that balloon angioplasty was performed. And after both inner and outer balloon angioplasty, we implanted the covered stent, and translesional gradient reduced to the 3 millimeter mercury, and electroendovascular treatment was planned for sacral aneurysm. What are the take-home messages? Coarctation of aorta may be overlooked even in patients underwent CABG surgery if coronary angiography was performed via transradial approach. Intracranial aneurysms usually coexist with coarctation of aorta, and coarctation of aorta should be considered in patients with bilateral lower extremity claudication and normal lower extremity arteries. Thank Thanks for your patience.
Yes, thank you very much for the very interesting cases. Now, open the discussion. Please give me a comment from the panelists. Dr. Chang, firstly, please.
Congratulations. I think this is a very successful case for this very rare medical condition. So my question is, do you check for this patient for cardio echo? Is this patient have abnormal for like BAV or some dilated ascending aortic?
Yes, as usual, we perform echocardiography in patients with secondary hypertension, and usually we measure the gradient at descending aorta. But the patient was evaluated before in different centers, so we don't know that if echocardiography measurements were performed before.
Okay.
Next, Dr. Gautam.
Yeah, it's nice learning case. I think it has shared that we have to, even if we practice the radial intervention, we need to check all the pulses like femoral and others, because this case have been evaluated earlier, for all the pulses might have been detected earlier, because intervention already has been done from the radial route, and he has said that it might be a drawback of radial intervention, but I don't think that it's a drawback, but it's learning that we have to evaluate as a whole and all the pulses. Even we are using radial, we have to look for other pulses during evaluation. Yes, thank you. Nice case.
May I ask one question?
Oh, please, John.
So thank you very much, first of all, for your nice presentation, and I would like to ask you for the cerebral intervention. So for the neural intervention, you are using the mostly radial artery approach or the femoral artery approach?
In Turkey and in our hospital, usually intracranial interventions were performed via interventional radiology, and in most cases they use femoral artery.
And thank you for your answer, and could you please tell me what was the blood pressure before you have done the procedure? I think it was high because of
his
the
blood pressure was normal, in normal range, but his medications was including 3 antihypertensive drugs. But after the procedure, we discontinued the spironolactone.
I see. But usually, when you are doing the CT angio before doing any intervention in intracranial artery, we are just going from the thoracic aorta, yes, and extracranial artery, and then intracranial in CT angio. So you did the CT angio just in intracranial artery part, or you have done extra also? And haven't you realized the coarctation before in CT angio?
The patients, the previous history was all in another center, but he presented with a cerebral event in our emergency room. So we only performed cerebral and head and neck CT angiography. We didn't evaluate the lower part of the aorta.
Yeah, thank you very much. Thank you.
Thank you very much.
Okay, other comment? No? Okay. Time is limited. Thank you very much for presenter and then the discussants. Very nice 6 presentation and then the very good discussion. Whole case very educational and then they very supported for our daily practice. Thank you very much for finished in this session. Thank you.
Thank you.
Thank you.
Bye-bye.
Bye bye.